Hi, everyone. Welcome to our Unit 3 discussion here in ST 135. Bear with me this week. I am feeling a little under the weather. The crud has hit my household, and I woke up with a sore throat. So we'll see if we can get through this. All right, so this week we're going to talk about drains and catheters that we use in the operating room. So that's our objective for this week is just identify those, their uses, and how you as a surge tech what you need to know about them, how to put them together, that sort of thing. So here are your assignments for this week. Not a whole lot, nothing too crazy or overwhelming. You do have your weekly discussion. Remember, your first post is due Wednesday, and then go back and respond by Sunday. Some of you are still forgetting to go back or forgetting to even include sources. I can't give you a grade on something you didn't even put. So you have to put some sort of source for your discussion post, okay? Even if it's just your regular textbook, that's perfectly fine. All right, so what is the difference between a drain and a catheter? They seem like they would probably be pretty interchangeable in the terms, and sometimes they are loosely used interchangeably, but they are slightly different things. So a drain is what's pictured here, and it is more than likely a temporary thing, okay? Catheters tend to be a little bit more long-term or maybe even permanent in some cases. But drains are typically short-term for drainage of wounds or incisions, okay? So we're going to talk about a lot of different types of both drains and catheters. They are sometimes hard to keep straight, so come back and reference this if you need to or before you take your certification exam. They like to ask questions about drains and catheters for sure on that exam, okay? So two main types of drains. We'll start here before we get into catheters. We have active and passive as our two broad categories, and it's based on how they work, all right? So an active drain is going to use some sort of suction or negative pressure to withdraw fluid, okay? Now, passive is usually just going to allow gravity to drain that incision. Nothing is actively pulling it out. No suction device, no negative pressure bulb that would pull it out. So two main types, and you really do need to know which drain is active versus passive, okay? So drains in general are used to remove fluid from an incision if they think it's a little oozy or if they suspect there might be a little bit of bleeding afterwards, remove air from the chest cavity, fluid from the common bile duct, there's a specific drain for that. And then the drain can also vary depending on the patient's anatomy, how much drainage or fluid is expected, maybe even sometimes surgeon preference, just depends. Okay, so here's one of our very most common types of drains. So this is an active drain, and this one pictured here is called a Jackson-Pratt drain. We sometimes just call it a JP for short, because who has time to say all words in the OR? It's fast, right? So JP drains come in two parts. You've got this little bulb canister collection device, and then you've got the tubing, okay? So this little bulb is sometimes called a grenade, okay? Just so you know. And then this tubing can be either, in this picture, is like a flat, or there's another one wound up that is round. So the surgeon will either ask for a flat JP or a round JP, and they can be different sizes, like a 7 or something like that. The bulb itself holds about 50 to 60 mLs or cc's. That would be something you should know as well. Because if you happen to need to empty this before the patient leaves the room, you need to A, let your surgeon know that it's already filled, okay? And B, record how much you have emptied. That's going to need to go in the record, and the surgeon's going to want to know how much. So if maybe this is full before you leave the room, the operating room, the surgeon may need to actually go back in and see what's bleeding so much. You know, if this is filling up very quickly, there's an active bleeder, and they're going to probably want to address that before they go to pack you. So I've seen that happen multiple times. We have to open that incision back up and then maybe clamp a bleeder, tie it off, bovie it, whatever, and then close them back up again. So keep an eye on this bulb. So the tubing gets attached to the top little port opening, and then there's an emptying port. So to assist the surgeon in placing this drain, okay, it's going to go in the incision. And well, it's going to lay in the incision. It's usually brought out beside the incision with a smaller incision. But you're going to squeeze the bulb with this emptying port cap open. Okay, squeeze it completely, as tight as you can, so there's no, like, very little air in there. Okay, then you're going to place the cap back on the emptying port while you're still squeezing it, and then you can let go. Okay, so that leaves room for blood to drain into. So it creates like a vacuum, a negative pressure in the collection reservoir. Okay, so then blood can empty into the tube. If we didn't squeeze it, there really wouldn't be a whole lot of room for the blood to go because it would just be full of air. Okay, so that is JP. The next one is a hemovac drain, also super common. Kind of the same mechanism, same concept as the JP, but it's much bigger. So it's for larger amounts of drainage that's expected. Okay. The collection reservoir is much bigger. It says it holds about 400, some up to 500 ml, so that's considerably more. The tubing has a very sharp, like a spear on it, okay? That's to put it through the skin next to the incision. So the surgeon will use that to poke through. They will then cut it off with a pair of bandage scissors or suture scissors, something like that. And then this sharp spear goes in your sharps box immediately, okay? It's obviously meant to puncture skin, so it will hurt you. Okay, and all these little holes, you see these holes here along the tubing? That's where they're gonna lay it in the incision to collect drainage. Now it can be cut to size if the surgeon needs it to be shorter, whatever. And it would get attached to your reservoir here. Same concept as the JP. You want to squeeze it completely, like an accordion in this case. Then close your port, and then you can let go. That activates it, so to speak. All right, another type of active drain. It's very similar to the JP and how it looks and really how it works, but the end of the tubing or along the tubing looks slightly different, okay? Now the JP didn't have these little channels. It had like a little bit more holes, but the Blake drain has 4 channels and it still can be flat or round. So it says it's more resistant to clogging. So if they're expecting a little bit more clots or clogging, this might be a better option. Could also be surgeon preference. So like I said, with the drain preparation, both with the JP and the hemovac, this is how you activate it or empty it. Okay, full drain, it's already been allowed to fill up. You empty the emptying port, pour it out into an appropriate container, whatever it is, and then squeeze it again while replacing the stopper. It's important that you squeeze it completely before you put that thing back on. That gives it negative pressure. All right, your other one is a chest tube. So these can be placed in multiple places and it depends on what they're trying to achieve. So sometimes you actually even have 2. You might have one in the lower chest cavity and one in the upper. What if you have 2, the one in the lower is to drain fluid, and the one in the upper would be to drain out air. There shouldn't be air in the thoracic cavity. For your lungs to expand fully, your thoracic cavity should be under negative pressure. It's the same concept as those drains, right? If you already have an entire container full of air and you're trying to breathe in, where's it going to go, right? You're not allowing yourself enough room for expansion. So as your lungs are now, hopefully, your chest is under negative pressure, which allows your lungs to fully expand. And for them to breathe out, it's just passive. All you're doing is relaxing your muscles. And because of the negative pressure, it's pushing it back out, okay? So chest tubes can be used to remove air, fluids, blood from the pleural space. That's the space surrounding the thoracic cavity or the lungs, okay? So anytime we do any chest procedure, if we have made an incision into the thoracic cavity, they will need a chest tube. And the purpose for that is just to reestablish negative pressure. It gets rid of that air. That's often also a certification question. Chest tubes reestablish negative pressure. Okay, so here's an example of one of those chest tubes. Common one is called a Pleurovac. It looks like this. It's like a big box sort of thing, hard plastic. It's much bigger than the other couple that I've shown you already. So it drains into here. It's got extra chambers for drainage, and this here is how it's allowing it to drain, like with the pressure variant. Okay, so it's a little bit odd looking, but really important with any drain, but especially chest tubes, that you are very careful with A, where this is placed, and B, like keeping track of it when you're moving a patient from bed to bed. Because if you accidentally pull out a chest tube, that's a problem. You're going to get in trouble. It could be a big problem for the patient. They're going to have to go back in, put that back in, and it's not pleasant. You don't want to do that. So be very careful. And when you're moving a patient, you want it to be lower than the chest level to allow it to drain down. You don't want it to be up higher, or there's no drainage. That's going to happen. That's true of any drain. All right, so those were active drains. Something was actively drawing the fluid out. Okay, so here are passive drains. This first one is probably one of the most common passive drains. It is called a Penrose. Looks like this. Usually it's made of latex, so watch your patient allergies there. They do come in different sizes or diameters that can be cut to size. A lot of our surgeons would use them, maybe did like a small little neck dissection, but didn't want to put in a big JP drain. They would just cut a little piece of this Penrose, suture it in place like it's shown here, okay? And then at the end of it, since there's no bulb to collect the fluid, they would just put like some 4x4 dressing sponges under it and cut, like kind of sandwich it in there so it has something to drain onto. And they would change that dressing out every so often. And then they would eventually pull that stitch out, and then you can pull the drain out after so many days, a couple days. Okay, so this is typically for something that you're not expecting large amounts of drainage, just maybe a little bit. Another passive drain here is called a T-tube. So this is one that is going to be used to drain the common bile duct. See how it's T-shaped here? You got one end going towards the liver, one end going towards the duodenum. Okay, so if they suspect there were stones or anything like that, the other end of the T would go out to the skin. Okay, so it's to drain the common bile duct. All right, so let's move on to catheters. So here are our main categories of catheters. Typically, our mind probably first goes to urinary catheters, which is most common, okay? We're gonna have quite a few urinary catheters to drain urine from the bladder, but we also have some that go in the stomach, vascular catheters, and some that are used for dialysis purposes. Okay, so urinary can be in a couple categories, three main categories here. You have an indwelling urinary catheter, a non-indwelling, sometimes we call it a straight catheter, a straight cath, and then a suprapubic catheter. So if something is indwelling here, this indwelling Foley catheter stays in place. So it stays in place by a balloon, and I'll show you a picture of that here in a bit. Sorry about my hair just kicked off. And the non-indwelling is not going to stay in place. It's just for a short term. You're going to slide it in the urethra, catch it with the basin, the urine with basin, and then take it right back out. So it's just to drain the bladder once. And the version of that we always call it a Robinson or a red rubber catheter, it's non-indwelling. Then you have suprapubic catheters that require an incision. This could be due to bladder cancer or something along those lines where they had to do something a little more invasive. That still requires bladder drainage. Maybe their urethra is damaged, whatever reason. They need to still drain the bladder. So they can make an incision above it, place it in with one of those. So that's called a Mailcott or a Pezar, which I have pictures of both. All right, so the gastric catheters are usually to decompress the stomach. You can also use them to place like nutrients in, if necessary, like a PEG tube, which you would place while you're doing like an EGD. It's kind of like a 2-for-1 special there. An NG tube is called a Levin tube. That was on some certification exams not that long ago. A Levin tube is an NG tube that is placed anytime we do like major abdominal cases, we want to decompress the stomach, also allows for the stomach to be identified while we're working. NG means it's going to go through the nose into the jejunum, so it goes further than the stomach. All right, vascular catheters. These Grishongs and PowerPorts, geez, are still pretty common. They're to gain vascular access, or maybe this patient needs long-term cancer drugs. Instead of having to stick somebody a million times, you've already got that vascular access port right there. It's much easier. All right, dialysis catheters are for taking the place of what your kidneys do. Your kidneys are meant to filter your blood, gets rid of excess fluid, things that your body doesn't need, electrolyte balance, that sort of thing. So for some reason, if your kidneys cannot do that, you have to have one of these two types of dialysis. A peritoneal dialysis, which is the tin cup catheter, and then you could do an extracorporeal dialysis, which takes it outside the body and puts it back. Okay, so here's your indwelling Foley catheter. This is your typical Foley right here. So this is how it sits in the bladder. It's inflated with a balloon. You have a syringe in your kit, your Foley kit that is usually, depending on the size of the balloon, probably this is a 5 cc balloon. You'll have 10 cc's of sterile water, not saline, sterile water, okay? So you inflate the balloon with sterile water, 5 cc's end up in the tubing and 5 cc's end up in the balloon. Okay, it sits right on that urethral meatus where it exits the bladder. So it shouldn't come out unless it really gets yanked on, and then you're going to damage the urethra. So be careful with those as well. Then you've got this whole kit that hooks up to the drainage bag. It could look like this, it could be slightly different, but it's still similar. It has markings to measure how much is there, and you can visualize what the urine looks like, because that could indicate maybe, maybe we're working in here, maybe we damaged a ureter and there's going to be blood. You would see blood show up in the urine. So it's a good thing to visualize the urine. And then a drainage valve, if it gets too full, if we're in surgery, our circulator will save the saline bottles or anesthesia, and they'll empty it into that. It's just kind of an easy little thing to empty it into. And it measures it. So here's some other urinary catheter tips. So we had our standard Foley, okay, which kind of looks like this. The Robinson is similar to the Foley, except it just doesn't have that balloon for the indwelling part. Council, I don't see very often, but the Tiemann and Coudet are very similar, and sometimes those two are used interchangeably, the terms. The Tiemann is sometimes called a Coudet, Tiemann, vice versa. Okay. Now these two right here, the Mailcott and the Pezar, are not urethral catheters, okay? Those cannot fit inside the urethra. These are going to be the suprapubic urinary catheters. These are two that you have to make an incision into the bladder to place. So they would stay in place because of their shape instead of an actual balloon being inflated. So the Mailcott is sometimes called the wingtip, and the Pezar is sometimes called the mushroom tip. Okay, so let's move on to some surgical dressings as well. So all these are kind of done usually at the end of the case, but here are a few of your, let me move this down a little bit, classification of wound dressings. So you have your bioactive dressing, something that's going to have an agent in it that will help it heal. You have traditional skin substitutes and interactive dressings. Those are your main categories, and a lot of them, there's so many dressings that could fall in these categories. So let's look at traditional, for example. Advantages. It's going to stop the bleeding. It's going to provide cushion and support. But it doesn't really allow for good gas exchange. Sometimes it could impede some healing, depending on the type, okay? So your plaster, cotton, gauzes, those are all traditional. Now your skin substitutes can be like a skin graft, right? So it could be an autograft, which comes from yourself, or an allograft, which comes from someone else, another human, and a xenograft would be from another animal, okay? Then you have interactive dressings that says reliable, longer shelf life. You've got different types of foams, films that are going to promote healing in that way. And your bioactives, alginate, hydrocolloids, these are good for especially burn patients. Okay. So your ideal wound dressing, these are what we're shooting for every time we have a wound dressing that we're trying to place. We want it to be clean for sure, right? When we are placing that dressing on at the end of the case, make sure you're using a pair of clean gloves. If you've double gloved, you could probably take that outer pair off at that time, okay? Removes exudate. Exudate means drainage, so it allows some way to remove that drainage. It prevents other pathogens or bacteria from getting in the wound. You want to prevent, we'll call it an SSI at this case, okay? Easy application and painless removal. That could be a big concern, especially for our elderly patients where their skin is really thin anyway. Dressing changes could make it worse. Like if they have really thin skin and you're pulling those dressings off, you can peel their skin right off with it. Their skin is paper thin. So you have to choose the right dressing for the right patient as well. Okay, it fills the cavity with no damages to perilesional tissue. And then, like I said before, gas exchange. Sometimes you just need it open to the air. So here are some pictures of some of those traditional wound dressings that we had just talked about a couple slides ago. So your gauzes, these are most common, okay? We do a lot of transparent films. Some of them are just one layer, some are multi. Like if you have ever had an IV placed and they put like that little, like it's this little, we call it an opsite, over top, that's what this is. You can see it sticky right on top. There's really no drainage that's happening there. Your foams, some of them have antibacterial substance in it. Hydrogels are hydrocolloids, and then hydroconductive. So you'll see all kinds. Depends on the surgeon's preference, patient skin, type of incision, so many factors. So one thing a lot of times in surgery we want is something that is going to be absorbent. We're expecting maybe a little bit of oozing, okay? So here's one example. It's called a C-sorb dressing. Sometimes call them, Tegaderm's a good example. There's several different companies that make something very similar. We have multi-layers that do different things. Your contact layer does allow for some transfer of exudate. You've got the absorption layers in the middle, and then the outer layer is fluid repellent and it keeps bacteria from entering, but still has some permeability to air. So it's basically a 3-layer dressing with 5 layers. You'll hear 3-layer dressings pretty often. So I wanted to show you some pictures of just some specific types or kind of unique dressings, especially this one. This one's called a Queen Anne's thyroid dressing. So if you're doing a thyroidectomy or even maybe a neck dissection, it's kind of a weird place to bandage there on the neck. So they'll actually wrap it around and kind of make like an X shape. And they've got a lot of gauze and maybe some fluffs underneath there. And then you obviously see your JP drain. Here, you see how it's, I don't know if you can tell from this picture, but it is squeezed, so it's flattened. It's allowing that fluid to be sucked out. Okay. So you might have multiple dressings just to cover one place. Depends on what you're working on. So this one starts with, this yellow stuff is Zeroform. So it's non-adherent, but it has like an antimicrobial substance in it. So Zeroform, and then a little bit of an absorbent dressing with a bigger one over top. And then it's secured in place because this one doesn't have any sticky to it. Secured in place with Coban, which is kind of self-sticky to itself. Now, that was probably the best choice here because it's really going to be hard to tape something so big right here, especially on what appears to be an elderly patient's hand. Here's another unique one called a bolster dressing. So we do these pretty often if there's some sort of skin cancer. We have to take a relatively big piece off and put a skin graft on, which is what this is here. It's what it looks like here from another area of the body. So it's a circle. It's not going to close well. Oops. I think I just went too far. Well, anyway, I think it's going to let me go backwards. What happened? Anyway, the bolster dressing, you will place something like a cottonoid or a big, we call them a bolster for the bolster dressings, or sometimes they're called dental rolls, and suture it on top of the skin graft. The whole purpose of that is to keep pressure on that skin graft. You don't want blood to get under it because if it does, it's not going to heal. That graft will actually float away from where it needs to heal from. So we want to keep pressure on that skin graft so it can heal. Okay, and I believe that was my last slide, so maybe that's why I did that. So if you have any questions or concerns, please reach out to me. I do have office hours on Tuesdays. If that doesn't work for you, just shoot me an email or something. We can work something out. But you guys have been doing really well so far, so keep up the good work, and I will see you next week.